Morning all. Good morning all. Thank you for joining us. This is the Aster RV Hospitals academic series, basically focusing on the recent updates based on the individual specialties. Today, it's my pleasure to introduce Dr. Raghavendra. He is our child psychiatrist who has joined us recently. He's fairly accomplished. I'm going to allow him to introduce his specialty and himself a bit more in detail so we understand how best we can acquire his specialty services. Over to you, Dr. Raghavendra.
Good morning, Sujata ma'am. Thanks for the very kind introduction. And whatever accomplishment which you said is actually courtesy of Nimans. I am just an ordinary person, but it's Nimans is what has made me what I am now. And I'm very blessed to be trained from a place like Nimans. So I will be, my structure of the presentation will be like hardly 10 minutes of slides, and I'll just tell what can be done and what are the options available and services available, and then I'll keep it as a more of an interactive session, and so that we can exchange what are the ideas and what is the client base which you people see, and what are the difficulties in terms of handling mental health issues which you see, and to address those issues. So when Sujata ma'am approached me to talk about recent advances, I was wondering, because there are quite a few recent advances in child psychiatry, but talking about them will again make it more too it will be like too over the head transmission, and it will become too confusing as well. So I realized, and child psychiatry as a super specialty itself is a recent advance, I would say, so to say. It's hardly 9-10 years old, and Nimans was the first one to start it. And so I thought maybe, and my professors always told us, you people are like cardiologists who were 20-25 years ago, it just started. Cardiology as a discipline just started as a super specialty, and it was they were also had their own challenges when the super specialty began. So you will have your set of challenges, but you are the earliest birds in the field, is what our professors told us. So to start with, one moment. See, world over, psychiatry and child psychiatry are usually different streams. You can't be usually you are a child psychiatrist alone or a psychiatrist alone. Being both is a bit difficult, and usually licenses are also different. But unlike in India, what was happening was there were child guidance clinics and other things, and a psychiatrist would be posted over there, and he would specialize in that and build that, and then he would become a child psychiatrist. And postgraduates would be given training in child psychiatry for a 3-month or a 6-month period, and it was a subspecialty. It was like a fellowship was started, or a subspecialty, but there was no super specialty plan. But since 9 years now, PGI and Nimans both have DM in child psychiatry, super specialty, and that itself is actually new. And there are hardly there are hardly some 8 to 10 child psychiatrists, 10 to 12 child psychiatrists in India actually now, and some of them have gone off to UK and Australia as well. So what are the differences between a subspecialty, having in a subspecialty and a super specialty is like, so the training will be broad and very general, very diverse and in depth, and this is on top of the 3 years general adult psychiatry experience. So with that, a child psychiatrist will be able to deal with perinatal cases. So we know the child development starts in utero, so address issues which in a perinatal lady, antenatal lady, so minus 9 months. So we can say right from the conception till 18 years, a child is an adult. So a child psychiatrist can play his role in a super specialist child psychiatrist. And if he wants, he can follow it up through an adulthood as well, which I am doing to some of my clients now. And why is it needed now? Why is it the need of hour? Because before Corona and after Corona, before Corona, whatever difficulties existed for children, now it has got compounded. And there are tremendous disruptions in the society which has happened. And there are emergence of new social evils. So school dropping out of school, which had actually come down significantly, which had stopped. Now children are dropping out of school, especially people now people from the lower socioeconomic strata in government schools. They now God knows how many will return back to their schools once it opens up. And re-emergence of old ones. There are reports where children are getting married at a young age and eloping, and so there are many social levels which are emerging, and there is hardly any focus on children because they don't have a voice. See, there is nothing. Children don't vote, so once nobody votes, they will not be catered to. So children are one of the least neglected sector in India. So, and why? Around India, around 40% of Indian population is less than 25. So around and again 25% is under 18. So 1/4 of Indian population is children, and children are not catered to. And mental health is a rights-based model. It's not a charity, or it's not any other model where they'll just open an asylum and drop off a child and leave the child. It's not like that anymore. It's a rights-based model, and children have their rights to seek mental health care. And so far, only NIMANS and PGI have the seats, and both have fellowship and DM. And but some more than half of them have actually kind of left India also. The people who have trained and come out, so very few people are remaining. So it's a highly imperative thing that others also start. Other centers also start training child psychiatry, start training programs in child psychiatry, so that mental health issues are not neglected. So this is just my profile, which has already been circulated. So I was the first rank holder for NIMANS in the exam, and in Bangalore there are whoever is available is in NIMANS, and in full-time corporate practice, I am the only one who is available, except for one more doctor who is in South Bangalore. And I'm also a qualified child rights advocate. So I have a qualification in child rights law, and I have extensive in-depth experience in clinical training and research activities. And I'm skilled in 6 languages. I'm
Dr. Raghavendra, you can now unmute yourself and talk.
I'm also highly skilled in capacity building and outreach, because this was a part of our super specialty programs where we used to train trainers, train people from NGO, train teachers in capacity building. So my vision and mission for Aster group of hospitals is to start OP clinical service, which has already started, and reach out services also have been started. And I plan to start inpatient services within the next 3 to 6 months, where we will have admissions for children with emotional disorders, and training and research, if possible, at the earliest, maybe within a year, where we can start a fellowship or a certificate course, or at least conduct CMEs and academic courses like a fellowship, a full-time fellowship with collaboration with some other universities. Something can be tried. So this is my vision and mission for Aster group of hospitals, and where again all the three branches are based on the logistical issues which can be planned, and developing models. So basically I have divided into early childhood, middle childhood, and adolescence. So this is a way to look at it, and where we can actually get a clear idea what are we looking at. So in early childhood there will always be a developmental issue. Later also there will be issues, but this will be more pressing and can never be neglected, and this can never take a backseat. And so with that there will be speech therapy, speech issues, fine motor, gross motor skills issues, and parenting issues. And parents themselves will be undergoing stress, and there are the developmental assessments needed and therapy needed to almost all children with early childhood issues. And to add to that, autism and ADHD will need medications for certain behaviors, certain targeted medication, pharmacological interventions as well. So in middle childhood, there will be academic issues, and school ready, and starting school, and difficulties in academics, and social skills issues, emotional and behavioral issues. And for that again, we'll need assessments, therapies concurrently by a psychologist, and many a times by a psychiatrist and psychologist, because the child will need IQ assessment, and the child will need academic interventions. And parenting will be an added area of focus over here as well. And adolescence, again, the adolescence, though, we know it's like a lot of adolescent issues, oppositionality, and emotional issues, behavioral issues, which are compounded by the peripubertal changes, and there are self-harm, suicidal tendencies, and there will be concurrent academic difficulties, and parenting will again be focused. So these are the areas which I can play a significant role. Certain areas like certification for intelligence, I cannot issue a certificate for intelligence, but I can still do an assessment for intelligence, and I can talk to the school, liaise with the school about the inputs the child needs from the school, the support a child needs from the school. And parents of children with mental illness, so start taking up sessions for them, separate sessions for them, and more than anything, building a team which consists of psychologists, social worker, and counselors. So these, and leading the team and leading a multidisciplinary team is also one expertise which I have. So and have separate sessions for these kind of parents, and a support system and medications for them. So again, basically a comprehensive and a thorough mental health service for a child, because a child will need intervention not just for him, it will need interventions for its environment also. So parents will be stressed and they will displace it onto the children. So and parental stress can affect children. So all those things will be addressed. So a comprehensive, and maybe even develop a package where all this can be included, making it less burdensome and more satisfying for the families, and to minimize the dropout rates. And coming to this thing, evidence-based treatments now. Pharmacotherapy, there are all class of medications, antidepressant, anti-anxiety medication, antipsychotics, sedative hypnotics, mood stabilizers. So all these medications I'll be handling. And developmental therapies for global developmental delay, speech delay, social communication disorder, any other development of gross motor, fine motor development issues. So everything I can handle, I'll be handling these issues. And parenting programs. So how to parent a hyperactive child, how to parent a oppositional child, and a child with disruptive disorder, say a child has school refusal and has truancy. So addressing the parenting issues, having imparting skills to parent a child with difficulties is one of the area of expertise. And focusing on the goodness of fit. So how a parent should tune himself to the child, and how a child should tune himself to the parent. So addressing the fine tuning issues is very important. because we know each child is unique. So the parenting also will be unique for the child. And behavior therapies, cognitive behavior therapies, and other related therapies for anxiety, depression, obsessive compulsive disorder, post-traumatic stress disorder, disruptive disorder, and eating disorder, anorexia, bulimia. So social skills training. So many of all these issues I'll be handling. And family interventions, where there are parental discord, and parental discord is affecting child. So family intervention in terms of helping the parents to handle their uh, uh, disputes, and then thereby not affecting the child. So and mother child interaction based. So imagine a puerperal lady who is in depression. She has um, decrease, she is paying less attention to the child because of her depression. So focusing on the mother child interaction based therapies, so that the child does not have difficulties in attachment to the mother. And then attachment issues are a base for the further social relations for a child. So difficulties in attachment can have a long lasting effect many a times throughout life. So mother child interaction based therapies and attachment based therapies, which I spoke just now, especially because attachment, a child with insecure attachment or avoidant attachment, they go on to relate to people in their lives later on in the same manner. So they will have difficulties in relating to people. So those kind of therapies also which has a psychodynamic thing plus attachment based approach. And play therapy wherein interpreting child's play, making the child and making the child understand the processes through play, through stories, through play. So this is another area of expertise which I deal with. And educational interventions, again, liaising with school or alone, I can take it up, but usually this will need a special, this is very time intensive, and a special educator or a counselor, and especially in liaison with school, is the best way to go ahead in these kind of situations. But leading this and supervising and monitoring these interventions is also a very challenging task, and I am adept at doing that. And school-based interventions, again, where um, liaising with the school, and the school mental health itself is a big issue, because children spend at least 8 hours, I mean, not in the last 1.5 years, but they have been spending, children spend around 8 hours in the school daily, and at least for 5 to 6 days a week. So significant portion of their life is spent in school. So school-based interventions are always a must for children to give a comprehensive edge to the mental health issues. So school-based intervention, whatever aspects of school mental health, also I am skilled in handling it. And coming to neurotherapies, basically these are somatic therapies, or what we call biological therapies, electroconvulsive therapy, transcranial direct current stimulation, and transcranial magnetic stimulation. Here, ECT, TDCS, and RTMS are very less frequently used in children, because of the ethical issues, consent issues, and there are the evidence base is also a bit limited. But at NIMANS, there are situations where we have used ECTs and these TDCS and RTMS for children. And RTMS and TDCS are more acceptable to parents rather than ECT. They have this worries about ECT. So with that, I will end my presentation, and I'll open it up for discussion.
Thanks, Dr. Raghavendra. We have a few people joining as well. From my perspective, I just wanted to understand, you said about the scope of services. I think as pediatricians, we have limited knowledge about each of these. Okay.
Yes, ma'am.
So from your side, can you tell us, which are the cases you must have been managing a few cases so far? what are the early warning signs that us pediatricians need to recognize so that we can provide the right help?
Ma'am,
How do we go about
which
it?
age group, ma'am? If you specify
You
the age
can
group.
start with us. So we have in our group, we have neonatologists, we have pediatricians, and so you can give us a rough idea on what the early warning signs are based on age,
Yes, ma'am.
so that
Ma'am,
we provide the best service to children.
yes, ma'am. Ma'am, infants feeding issues, sleep issues, they are the earliest predictors of temperamental difficulties. So child is not sleeping at night, very crying for no reason, and has coexistent neurological conditions, had hyperbilirubinemia, had and possibly had kernicterus. So these are the signs where there is uh, short possibility that there is an evolving mental health issue in the offing. So mental health issue and developmental issue. So both, especially children who have problems in self-regulation, that is sleep regulation and biological rhythm regulation, to put it in that way, at an infancy level. And at a preschool age level, it's very important to be mindful of child's developmental issues. Again, as the red flags, so-called red flags of development, if there is an issue in that, then that is one thing. And if there is a if you notice a parental, if there is a sense of parental discord, parents are not on the right thing, and there are some fights going on in the parent, then it will manifest in the child getting understimulated. So any developmental delay can have various factors. So these developmental delays are always best addressed at the earliest. So that is the one thing I urge pediatricians to pick it up very soon. Pick it up, and appropriate assessments wherever possible, however possible. Appropriate assessments are very indicated. Because parents tend to feel that, parents tend to normalize it. Your mavango hage ittu, his uncle had this, his father had this, his grandmother had this. So he will also be fine with speech delay. He will also be fine with motor delay. He will grow out of it. Parents tend to, they have this idea, they carry this notion. So that has to be changed in the minds of the parents, because any developmental delay will have a spin-off effect into mental health issues, emotional issues, and behavioral issues. And that is the preschool issues. And in middle childhood, what we can look at is academic issues, having difficulties in school, even the slightest difficulty in academics. There can be underlying developmental issues or emotional issues, and even feeding issues. These kind of children will start becoming more withdrawn, more anxious, clingy to parents, and refusing to separate from the parents, repeated reassurance seeking. So these are the warning signs of emerging emotional disorder, emerging mental health disorder also. And oppositionality, child becoming cranky for no reason, crying for no reason, and back answering parents for no reason. So these are the signs where sometimes parents tend to feel that it's fine, it's normal, but many a times there is an underlying issue which the child is unable to talk about it. It has bottled up those issues, and then it's kind of manifesting in a different manner. So these are the signs. And especially in adolescence, adolescents usually have their own ways of connecting to friends. They don't usually, they trust more of their developmentally, they prefer connecting to their age related peers rather than um, their parents. So parents find it challenging to tackle adolescence. So any adolescent issues where the child is more looking withdrawn and down, or not giving interest, and spending more time on gadgets, spending more time in outside home. So these are issues where parents should talk to the pediatrician about these issues, and bring it to the attention, seek help at the earliest. And again, there are, if we go by specific disorders, I can even tell that, but these are a general bracket which I can tell according to the age groups. I think I should not go into the individual disorders because that will make it more confusing, is what I say. Hello, ma'am.
Sorry. Yeah.
Yes, ma'am.
We can just open up the questions to the floor as well. Otherwise, I will keep asking.
You're most welcome, ma'am. It's my pleasure to be answering any question.
Any questions from Whitefield team?
No, nothing questions.
Okay, I'm going to ask you one more thing, Dr. Raghavendra.
Yes, ma'am.
So we have had during the COVID season, we had quite a few kids that we ended up managing, for partial hanging. And these were all like 14-year-olds. So what could we have done better? And, how do we raise this awareness so that this doesn't become a trend?
Yes, ma'am. Ma'am, what we see is the attempting self-harm is like the child would have overcome several checks and balance and have felt that this is the last resort. So there are some 3-4 checkpoints before which the child can be screened and can be intervened, and the unfortunate incidences of self-harm can be prevented. First is the parents have to be a bit more connected and more observant, especially in adolescents. Without giving them a feeling of being monitored, being micro monitored, the parents still have to be connected, spend good time with adolescents, take them out, play with them. So that is the first thing, that then they will get to know that there is something wrong with my child, is not like regular. So that is the first thing. And usually these children whom you spoke about, the partial hanging, consumption, this is skyrocketing nowadays, like you said, now. They would have given some signals beforehand, like slashing their wrist, or telling that I don't want to live, or telling that I'm not feeling well, or there is some issue, some somatic symptoms also sometimes manifest, or school refusal. So there are some things which would have manifested, and many a times parents would not have noticed it, or thought it's fine for a child, and they would have left it. That is the first checkpoint. Then the next checkpoint will be where the parents themselves are a bit disturbed, the family environment is a bit disturbed, and they are unable to focus on the child. So then the child feels there is no help. So that is the second checkpoint. And the third checkpoint is, again, there are some other stresses added on from other environments. So intervening at these checkpoints and being mindful of these checkpoints, like say a child comes with 2 days, 5 days, 10 days of emotional withdrawal, dull behavior, talking to the child and making the child understand and asking him what's going wrong, anything which is troubling him. That is the first step. So that will open up a lot of venues for the child to ventilate his feelings, his or her feelings. And that so the child will never be in the trajectory to self-harm. So so-called primordial prevention, primary prevention, and secondary prevention. And there are many cases where many of these could have been done, but have been neglected either by the school at times or by parents at times. So pediatricians are the ones who can actually intervene. They are very much in touch with children, and they can bring the child off that trajectory. And doing better, ma'am, primordial screening would be the starting to screen a child for emotional issues whenever they come for a regular visit, whenever they come for other physical illnesses, screening them for just for 2 minutes. Is everything going? How are things going at your school? How are things going elsewhere? So even such a simple question, actually we have seen children open up, and they just open up. They tell many things which they couldn't have told to anybody else, especially parents. So just 2 or 3 simple questions. How are things going? Who are your friends? What are you doing with your friends? How is life going? So these kind of general questions also we have seen just help children a lot. So that is one thing. And when they're the next step will be to counsel the parents also to be watchful whenever they come. No, any any symptom can portend a mental health issue. And it can have a mental health angle. So always to be watchful of that, and then report at the earliest is one thing.
Okay, thank you.
I have
any
a
other?
question. Yeah.
Yeah.
Hi, I'm Dr. Nandita. So we also deal with a lot of liver transplant children. They have a lot of complex pathophysiology, especially few children we even came across having behavioral disorders because of underlying Wilson's and other diseases. Is there something we can do from pre-op and also follow up like in the ICU and then post-op period from your any inputs where we can handle it a little more better is my question.
Yes, ma'am. Definitely, ma'am. In terms of especially a child's understanding about a transplant, the processes involved, that itself is very confusing. The children, they don't understand things the way we tend to understand. The grown-ups tend to understand. So they tend to get very anxious. They tend to, and the concept of death, dying, and all this long-standing comorbidity, children, it's not fully evolved in them. So they tend to get very anxious. So a solid mental health support for the child in terms of making the child understand. I mean, the counseling before transplant is one thing. Yes, that is done. But making the child understand it and the processes it will go through, and how he or she is supposed to handle those difficulties is one issue which can be focused upon. And on top of that, if there are any other like anxiety which is syndromal and which needs medication, that can also be tried. And post transplant, again, support in terms of parental understanding, parental caregiver burden, and the child's especially these kind of children will not be able to interact with other children much. They will have to be homebound and with limited mobility. So that can again lead to a lot of emotional and behavioral issues secondary to this transplant related. So these are the issues which can be tackled and addressed. That will give a comprehensive edge to the treatment intervention, and the quality of life will improve manifold in these cases.
Thank you. Any other questions?
Sir, I have a question. Like along with you, who else is a team member, sir? Like, do you have here child speech therapist, occupational therapist who are specifically trained in pediatric neurology and pediatric psychiatry, like autistic screening and all? Who else is there with you?
At
here?
Aster RV, there is this entire team which is which has a physiotherapist, speech therapist. We sit at LBJ, Aster Clinic, so that it's more comprehensive and it's a one all solutions under one roof. That concept. So this has speech therapist, occupational therapist, physiotherapist, psychologist, and a child psychiatrist. A pediatric neurologist is at Aster RV, so we liaise with them in these scenarios. And at CMI, I sit in new kids, so that again everything is under one. In new kids, it's a comprehensive place, and so to say, even at Whitefield, it's the same. So there is a team which is operational. In fact, the team was already there, and I plugged into the team, so to say.
Okay. And we have to refer you to the Aster RV clinic, right? Not hospital.
Yes, LBJ. Yeah, third floor. I sit in LBJ, third floor.
Okay.
Little Blue Jay thing. It's the third floor of Aster Clinic.
Timing, sir? Like.
See, so far, since I'm located in JP Nagar, I go there almost 3 to 4 days a week. But eventually, I might condense and make it 2 days a week, or depending on the caseload.
Okay.
What can be done is the secretary over there, Sunita, can be contacted, and she will fix up an appointment with me. So
fine. Okay, sir. Okay, thank you.
If there are no further questions, we could probably just end the session. So I'm sure we'll have a lot more questions, after the session ends. So we can try and contact Dr. Raghavendra. If you can just flash up your contact details, then we'll try and just reach out. So from RV, Reena will be the coordinator for us from within the hospital to connect with Dr. Raghavendra. Thank you so much for your time and, giving us an overview of the scope of services, because it's important for us to know how to identify and when to refer. So thank you so much.
Thank you, ma'am. Thank you. And have a great day wishing a great day, all of you. Thank you, ma'am.
Thank you all.